as AIMA as a General Secretary. I'm also one of the AIMA National Vice Presidents, Alhamdulillah. And so why is today's webinar really exciting is because we're speaking about important things such as food in terms of people that are unwell with diabetes. We're speaking about women and the issues surrounding women in fasting. And we're also speaking about sleep, which is really important for us, inshallah. So coming to, before I introduce our first speaker, I just wanted to give a really quick recap of the format for today. It's the same as of our webinar before. So we're going to have the speakers speak. And if you have any questions in mind, please write them in the chat box as the session is going on. And at the end, we'll have time for question and answer. We'll also unmute the participants so that you can raise your hands if you have to ask any questions, but we'll leave that until the end, inshallah. And yeah, so if there's any issues along the way, please type it in the chat box and we can have a look at that. So we'll start with Dr. Marrwah. Dr. Marrwah Ahmadzai is an obstetric and gynecology registrar. She's an advocate for anti-racist medicine, women's health, and health leadership. Her writing has appeared in the SBS, Guardian, and the ABC, and she is a speaker who has made appearances on the national and international stage, including TEDx talks on the power of storytelling in breaking down barriers. Dr. Marrwah is a member of the Royal Australian New Zealand College of Obstetricians and Gynecologists and ONG Magazine Advisory Group. And she will be speaking to us about balancing fasting and wellness. I'm going to stop sharing my screen so that she can take it from there. Inshallah.
Jazakallah khair, Sister Suhana. I'm just going to share my screen. I'll just confirm that you can see your screen okay.
Yes, we can.
Perfect. So I'll just have a look at the time so we can keep an eye on things. So I'm talking about Ramadan and women's health, which is quite a broad topic. And there's a lot of areas to address that are, of course, not limited just to sexual and reproductive health. However, in the interests of time, I'll be focusing on these areas that you can see on your screen, with the greatest weight of our discussion being to pregnancy and breastfeeding, but we'll briefly mention menstruation, menopause, and infertility as well. So in my day-to-day, I tend to get asked a lot about pregnancy, so I thought we would start there. And I'm sure with all the other webinars, but with many discussions around Ramadan and health, we refer to the ayahs in the Quran where Siyam was mentioned. This is Surah Al-Baqarah. So the part of this verse that I wanted to raise your attention to was the part that says, Allah intends ease for you, not hardship, so that you may complete the prescribed period and proclaim praise of Allah for guiding you. So many of the recommendations made for pregnant women come from this Quranic principle of ease. So we know Islamically, women are exempt from fasting if they fear for their health or that of their baby, not just in pregnancy, but also with breastfeeding and other things. And despite this, we know that research states most pregnant Muslim women will still choose in fasting. And research states that up to 80 to 90% of women will participate in some form, if not for the whole month, at least in part. Now, if we think about this, given that a quarter of the world's population is Muslim, in any given year, there will be large proportions of Muslim women who will be pregnant or breastfeeding during Ramadan. And by extension, most Muslim children will have been exposed to Ramadan fasting in utero. So the natural place to start with a discussion around Ramadan and pregnancy is, what does the medical literature say regarding this issue? Now, just a note about, so I know that many of the people participating in this webinar are medical, but there may be many members of our community present as well. And I just wanted to bring your attention to the different types of evidence that we have in medicine. And that's demonstrated in this pyramid here. So the lowest level evidence is things like expert opinion, and the highest level evidence is things like randomized controlled trials, and systematic reviews are above all of those because they compile all the available evidence and look at their strength in order to draw conclusions. So in terms of the medical literature regarding this topic, there are quite a lot of studies, but most of it, unfortunately, is low-level evidence. We also see that there is quite a bit of contradiction in the available evidence. And there are no medical guidelines. There are a couple consensus statements. But my data I've drawn from an umbrella review of systematic reviews, which is essentially an article that's combined all the systematic review articles that are available on this topic to give the best evidence and recommendations. So this is the paper. The reference was on the previous slide, and it's been published this year for those that are interested. Essentially, systematic review, the review demonstrated that Ramadan fasting had no significant impact on gestational age at birth. That is, that it did not increase the risk of preterm birth. It also did not increase the risk of having a low birth weight baby, nor did it affect the baby's growth whilst inside the womb. So how we measure that is on growth ultrasound scans, the different growth indices for babies. There was also no evidence that Ramadan fasting increased the risk of revision. What it can do is reduce fasting blood glucose, but it does not change the risk of gestational diabetes or the risk of preeclampsia. Interestingly, a positive finding was that it may reduce the amniotic fluid index, which is condensed to AFI in that line there, because Ramadan fasting involves, of course, refraining from all oral intake, including fluid in, and that can lead to dehydration, particularly for us in the Southern Hemisphere as we go into the hotter months. And so that's an important consideration. And also, fasting does not impact the condition of the baby at birth, which is measured medically by the APGAR score. None of the reviews had enough robust data regarding important outcomes such as stillbirth, miscarriage, or neonatal death, so we can't comment. But we do know that there was no significant difference in gestational weight gain between the fasting and non-fasting groups. If we look at weight gain during the month of Ramadan alone, the weight gain, unsurprisingly, was lower amongst the fasting cohort. So what I've just talked about was immediate pregnancy outcomes. There is also some data on longer term outcomes. So this is a systematic review published about 4 years ago looking at that, and basically summarizing data from 31 different research articles. And the same thing, it showed that there was no difference in birth weight or likelihood of prematurity. However, in terms of longer term outcomes, children exposed to Ramadan fasting did perform slightly poorer on cognitive testing, had a shorter stature, and in developing contexts, not developed context, childhood 3 and under 5 age group was increased. But it's important to consider there could be many other reasons for this. And the likelihood of hearing disability was increased. Now, this is important, but one of the limitations of this was that the evidence was largely of low quality. So I'm going to refer you to the British Islamic Medical Association Ramadan Compendium, which pens a few lines regarding Ramadan and pregnancy. And drawing on what we've just discussed, these are some of the recommendations. So the first trimester is the period of embryogenesis. It actually refers to the period the fetus is growing and developing. By the end of the first trimester, all the organs are fully developed. So this phase of pregnancy is very critical because because of the developmental theory of the origins of health and disease, which is also known as the fetal programming theory. So this part of pregnancy has long-term health outcomes, but it's also particularly vulnerable to environmental factors. Furthermore, women who are in their first trimester often have significant nausea and vomiting and will struggle with oral intake. And so for these reasons, hypoglycemia during Ramadan can be significant and could have a detrimental impact on a developing embryo. And as such, it would be reasonable to avoid fasting in this time. Well, women in the second and third trimester of pregnancy are probably safe to fast, given what we've discussed. But conditions need a risk stratification. So this is a discussion with a healthcare provider, either a doctor or a midwife, at least a month before, to decide whether they fall in the low, moderate. It's probably safe to fast. In the moderate group, they will need to be evaluated further, and the high risk group should avoid fasting. The earlier that this discussion takes place, the better, because it allows time to practice fasting, particularly in the month of Sha'ban. So there are also situations that are maybe pregnancy specific where fasting is not recommended. So what I mean by this is if a woman is well with no medical conditions, however, has a complicated pregnancy for another reason, she should consider refraining from fasting after discussion with a healthcare professional. These situations would include things like fetal growth restriction, twins or triplets, inadequate weight, severe insulin requiring gestational diabetes, or oligohydramnios, which is a condition where there is low levels of fluid around the baby, because we discussed that fasting increases the risk of further reducing the fluid. Now, pregnant women, due to the physiological demands on their bodies, may experience symptoms such as fatigue. They're already at risk of iron deficiency anemia being pregnant, and so they're at risk of dehydration, vomiting, diarrhea, dizziness, and weakness. So some of the other general pieces of advice we give is that if you are losing weight during Ramadan, consider spacing following symptoms, which could be symptoms of dehydration. Contact your healthcare provider and go in for assessment and break your fast. And interestingly, some of these symptoms are things that women wouldn't immediately consider to be related to dehydration, but maybe, such as preterm contractions or reduced movements. The other important consideration is that pregnant women are at increased risk of urinary tract infections by function of being pregnant, and then they're at greater risk when they're fasting because of dehydration. So important to get tested early. Now, some other general recommendations. In pregnancy, we recommend vaccinations and supplements. And as for vaccinations, most schools of thought in Islam feel that they do not nullify the fast. And as such, we would recommend taking them. So the three to be aware of is influenza vaccination at any stage of pregnancy, pertussis vaccination from 20 weeks, and newly introduced this year, RSV or respiratory syncytial virus vaccination from 28 to 36 weeks of pregnancy. In terms of supplements, even if you're fasting, you should be able to fit them in around your feeding schedule. So a pregnancy multivitamin is recommended pre-pregnancy and throughout. Folic acid at least a month before and throughout the first trimester. Vitamin B12 for vegetarians or vegans. Supplementation if deficient, and most Muslim women are. And iron supplementation, particularly from the second and third trimester. Some women with higher risk pregnancies will be recommended to take aspirin, and we know that the absorption is improved at nighttime, so better to take it after iftar. We also know that blood tests and ultrasounds do not invalidate the fast, so it's important to keep attending those appointments. And the only thing you may struggle to fit in is the oral glucose tolerance test, but there is a 1 month window in which you can between 24 to 28 weeks. So it's important to fit it in before or after Ramadan. In terms of food, I won't say too much other than consider the foods that increase your risk of listeria that's described in this infographic here, and avoid those foods. Now, moving on to breastfeeding, this ayah in the Quran, also from Surah Al-Baqarah, encourages breastfeeding for children up to 2 years. And this mirrors the advice from the WHO, which, subhanAllah, demonstrates divine wisdom. So exclusive breastfeeding is recommended for the first 6 months of life, and then beyond that, adding diet, but continuing breastfeeding up to 2 years. The reasons for this is that there's a lot of benefits for babies, including lower risk of infections, allergies, obesity, diabetes, childhood cancers, etc. And for women, cancers, osteoporosis, and a positive correlation with mental health. Now, thankfully, the data on Ramadan and breastfeeding shows that there is no significant difference on a macronutrient level between the breast milk of mothers who are fasting and those who are not. There may be a micronutrient difference, but there's no difference in the weight gain of babies during the month. Conditions to avoid breastfeeding in would include if you're exclusively breastfeeding, that is, if your child is less than 6 months old, if you have pre-existing issues with breast milk supply, or if you are a diabetic. Now, we know that breast milk contains a lot of important vitamins, minerals, fats, etc., but the main component is water, which is why if you're breastfeeding and fasting, the main take home is that you need to stay hydrated. Avoid spicy and salty foods that may worsen dehydration. Eat a well-balanced diet, as we've alluded to in previous slides, and be aware that your baby may feed more at night. That is normal. They may be more fussy. That's also normal. And beware to keep a track of their hydration and continue to feed the baby even during the day when you may not feel as much strength, because breastfeeding is a supply and demand issue. And if you're having issues, see a lactation consultant, because actually they are the most qualified in this area. The other option is to see a midwife, as all midwives, it is within their scope of practice to assist with breastfeeding. If you're having any issues, the best place to start would be the Australian Breastfeeding Association, but there are many local organizations. And this is just a slide for reference of how to know that whether your baby is getting adequate hydration or not. So last few slides, Ramadan and menstruation. Now, menstruation is controlled by a complex hormonal axis between the hypothalamus, the pituitary gland, and the gynecological organs. So the brain is actually the central command center that allows all of the hormones to be secreted. And it's under a complex interplay of different factors. So things like changes to sleep schedule, to diet, to physical activity levels will affect hormone function, and as such have downstream effects on things like menstrual cycles. So changes in the cycles are very common. Changes you may experience include things like longer, shorter, heavier, lighter cycles, or cycles that are coming closer together. Muslim women are prohibited from fasting during the period of Haid, which is menstruation, until they have the clear discharge that signifies the end of the period, or nifas, which is the period of postpartum bleeding up until 40 days. And research data suggests that there are some beneficial effects in terms of menstrual cycles for people who have polycystic ovarian syndrome, given things like improved insulin resistance during Ramadan. Now, many people will ask about prolonging their periods or stopping their periods. So a word on this is that it is actually divinely decreed that we don't fast during our periods. Scientific evidence does back this up in some ways. There's interesting data for women. Fasting more than 3 weeks actually worsens glycemic control, which is not something that has been observed in men. And so many women, when they have their period in Ramadan, end up the month. And that is not only divinely decreed, but also backed up by scientific evidence. Some women will have to consider taking hormonal medication for managing heavy or painful menstrual periods that interfere with their life, either in Ramadan or outside of Ramadan. And it's important to speak to a doctor and obtain treatment for this as early as possible, because if you start hormonal medications closer to the month, actually you may get irregular bleeding that makes it harder to fast. Menopause is a really critical time period in a woman's life, and women are often navigating a significant life change that brings with it a lot of physical challenges as well. The medications that some women need to take, hormone replacement therapy, are fasting friendly by and large. There are many topical administrations, so things like patches and creams. And if you are taking tablets, you can generally try and change the timing to take them at nighttime or suhoor. And just a few words that are, again, general, not specific to Ramadan. If you notice any perimenopausal bleeding, this definitely needs investigation to rule out sinister causes. In Ramadan, continue to take your vitamin D supplementation to reduce your osteoporosis risk. We know that fasting can improve your cardiovascular profile, which you are at risk of having cardiovascular issues in the menopausal period due to withdrawal of estrogen. And for those who are postmenopausal, we recommend multiple screening things such as mammograms, cervical screening, the fecal occult blood test, and annual cardiovascular screening. So it's important to do whether or not it be Ramadan. And the last slide is about infertility. So unfortunately, many couples struggle with infertility. And interestingly, prospective cohort study about this that shows that the live birth rate was actually higher in the fasting group than in the non-fasting group, which is not surprising given that fasting improves things like glycemic with weight reduction. Interestingly, the fasting group, when accessing artificial reproductive technologies, did need higher doses and duration of induction in order to achieve pregnancy, but the embryo quality did not differ. The pregnancy complication rate downstream was higher, but the anxiety and depression rate amongst women was lower in the fasting group. This data mirrors from retrospective studies as well. Of course, questions will be in the chat, but if you'd like to get in touch, these are my handles.
Jazakumullah khair, Dr. Marrwah. Mashallah, very, very concise points that you touched. And as a GP, very, 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 very relevant to every day-to-day things that I see in the clinic. Just a reminder to everyone, if any questions come up, please feel free to type into the chat box now, or you can wait until the question and answer session. So I just wanted to recap on your last point, which is really, really impressive about infertility and fasting, and how much literature there's out there about fasting improving the cell, reducing the oxidative stress on the cells itself, and hence increasing the chances for fertility as well. So that's a really important one. And just recapping back on the topic that you had today was balancing. So it is a balance. As a Muslim GP, as a Muslim health professional, when patients come to us asking between deen and dunya, I suppose, we have to give them a balanced answer. And as you highlighted in the beginning, it is individual, but individual case-based. And you should discuss it with your medical health professionals, because your situation might be different compared to someone else. And it's very empowering to see evidence, because we practice evidence-based medicine. So now we can, in fact, reduce the prejudice that people might have by providing them evidence that is, that was thought of lacking. Inshallah. And I think, yeah, so that was very empowering. And I've got more questions, but I'm going to keep it till the end. Jazakumullah khair, Dr. Marrwah. So before we move on to the next speaker, again, just a reminder, type your questions now. You might forget them later. So moving on to our next session, the speaker that we've got is Dr. Nisa Shareef. She's a Sydney-based endocrinologist. She completed her endocrine training through the Royal North Shore and St. Vincent's Hospitals, Sydney. She works in public and private hospital with appointments at the Sydney Adventist and Hornsby Hospital. She runs the maternity endocrine clinic at Hornsby Hospital and is involved in research, physician training, and registrar supervision. The title of her talk today is Ramadan and Diabetes, Smart Strategies for a Healthy Fast, inshallah.
Assalamu alaikum. Can you hear me?
Yes, we can, Dr. Nisa.
Is my screen sharing?
Yes, we've got your screen, which is not full screen yet.
Okay. Are we good?
Yep.
Okay, Assalamu alaikum, everyone. Thank you so much. Thank you, Dr. Suhana, and thank you to the organizers for asking me to present on this topic. It's obviously quite timely prior to Ramadan, and it's a really important topic because I think there's a lot of healthcare avoidance surrounding diabetes, particularly because of the perceived notions of healthcare professionals' attitudes towards Ramadan and fasting. So it's really important for us to dispel that and guide patients safely through Ramadan. So as we know, fasting during Ramadan, it is a form of intermittent fasting, but with quite a unique glucose profile. So there is not necessarily reduced caloric intake through the course of the 24 hours, but the caloric intake is concentrated during a few hours of the day. So what we have on the left is a fairly stable glucose profile of someone without diabetes, with three main meals, and with relatively lower glucose levels as they enter the evening through the period of overnight fasting. In the second profile, we see what happens in Ramadan, where there are relatively lower glucose levels during the day, and then these peaks and troughs, and a large glucose spike fueled by the large carbohydrate load, which often is what we consume during iftar. And then the lower line here is just a prolonged period of fasting with no intake. Below it is a representative sleep profile, and we know there are changes to sleep, fluid balance, energy during Ramadan. Now, this might seem a little bit luxurious if we look at this, where in the top line we see awake during the daytime hours and a period of continuous sleep overnight, whereas during Ramadan there is discontinuous sleep with segments of sleep before suhoor, some sleep after suhoor, and a luxurious afternoon nap. I think it's important here to acknowledge that a lot of the data regarding this comes from countries that are predominantly Muslim majority. And so the sleep deprivation is likely to be more significant in people trying to maintain regular schedules in Western countries, for example, where we are abiding by the rules of school timings and work timings and whatnot. So the sleep deprivation becomes even more significant. We know that sleep deprivation is associated with metabolic changes, with increase in insulin resistance, increase in stress hormone levels like cortisol, growth hormone, which can in turn impact our metabolic health. So this is just fasting representation in people without diabetes. So as we see, food is ingested, which in turn stimulates insulin secretion from the pancreas. This promotes storage of this glucose as glycogen in liver and in muscle. And then in periods of fasting, we see there is no glucose intake and therefore a reduction in insulin secretion. this increases production of the counter-regulatory hormones like glucagon, and other catecholamines, which stimulate gluconeogenesis or glucose production from the hepatic and muscle stores of glycogen. So this is a beautiful little graph of the relevant substrates over a 24-hour fasting period. So I will just draw your attention to, firstly, to glucose and insulin. So we have in the fluorescent green line is glucose, and the dotted orange line is insulin. So obviously after likely some carbohydrate intake, there is a decline in the glucose, small decline in the glucose level and the insulin level, followed by a period of relative stability in these two. Concurrent to that, we are seeing an increase in glycogen, which is helping to maintain that glucose level. Now, in this steep black line, continuous black line here, we see that the glycogen stores are being depleted in order to maintain that relative glucose stability. And by the time we are around 8 to 10 hours into that fast, we are starting to see a shift from glucose metabolism to fatty acid production. So we have an increase here in the black dotted line of free fatty acids, which are being released from adipokines, and these fatty acids are what are ultimately then metabolized into ketones, which are represented here in the dotted brown line. So in people with diabetes, there is relative insulin resistance and or deficiency. And so this shift that we see from carbohydrate to lipid metabolism can be accelerated, leading to excessive glycogen breakdown, increased gluconeogenesis, and quicker production of ketones, and then ketoacidosis, which is more prone to occur in people with more significant insulin deficiency, like in type 1 diabetes, or in people with relative insulin deficiency, like we see in patients treated with SGLT2 inhibitors. So as we know, there are many benefits to fasting, spiritual and mental well-being. We have seen in studies that there may be reduction in stress, anxiety, and depression levels. It can increase a sense of self-control and empathy. We do see metabolic benefits, and studies have shown mean weight reduction of around 0.8 to 1.4 kilograms during the month. However, much like any other form of dieting, the body weight reduction is short-lived and generally regained by around 4 to 5 weeks. We see other metabolic improvements in LDL cholesterol and triglycerides. However, there are some other there have been negative impacts observed in patients with diabetes as a consequence of the sleep deprivation and the increase in stress hormone levels. There has been observed to be an impact on mental health and cognition, with some studies suggestive of mood deterioration, irritability. And we also have to consider the real fear of hypoglycemia that's perceived by many patients entering Ramadan when they have diabetes. Whether this is a valid fear or not, it's up to us to assess and potentially reassure patients. So as we heard, Allah did intend for Ramadan to be easy, and there are many exemptions for fasting. As we heard in women who are menstruating, pregnant, breastfeeding, people with cognitive impairment, and the elderly. Now, as we know, type 1 and type 2 diabetes are chronic illnesses, and patients are permitted not to fast during the month. But we have seen high levels of fasting in people with diabetes. And so this is a large retrospective survey, the EPIDIA study, the Epidemiology of Diabetes and Ramadan, conducted in 2001. And they found that almost 80% of type 2 diabetes patients and over 40% of patients with type 1 diabetes fasted for at least half the month. So I would love for more people to ask this question: can I fast? And I would really hope that people are seeing more Muslim patients coming to them before Ramadan to have this discussion. But unfortunately, I think what we do see is real healthcare avoidance around this time, and people trying to attempt it without proper guidance. So generally, people will fall into three categories: people who wish to fast, those who are genuinely undecided and seeking medical advice, and those who have already decided that they will not fast. This is a very individual assessment. There are certainly no rules for people with diabetes as to whether they can or cannot fast. And ultimately, it's up to us to support the person with diabetes to maximize their safety through the month and educating them as fully as possible. So in preparation for Ramadan, it is advisable that patients seek healthcare through their GP, endocrinologist, diabetes educator, or dietitian at least 4 weeks prior to Ramadan, so the changes can be implemented and trialed. It's a time during which we really should encourage healthcare attendance, and lots of strategies are in place. They could trial a few fasts during the month of Sha'ban, or trial Ramadan foods with close glucose monitoring to see the outcome of various foods on their glucose profile. And ideally, we like to avoid commencing new medications very close to Ramadan, so at least 2 to 4 weeks prior is ideal if we are planning to. So what is this assessment? So we want to quantify their risk. Is this patient safe to fast? We want to discuss the role of self-blood glucose monitoring, provide advice on when it is permitted to break the fast, when and if to exercise, fluids and meal planning, and perform appropriate medication adjustments. So this is a tool that has been created by the IDF, or which in this talk refers to the International Diabetes Federation. It is freely available on the internet. And like Dr. Marrwah said, a lot of our studies in this sphere really are derived from low-level evidence and expert opinion rather than large studies. So using this guideline, there is a point system allocated to particular risk factors, and patients are given an aggregate score. If they fall between 0 and 3, they are considered low risk, and fasting is likely to be safe, and people can go ahead. If they're in the 3.5 to 6 score, there is a moderate risk of fasting, and really it's an individual decision, and clinicians and patients need to take into account their particular unique diabetes experience and whether it would be appropriate for them to fast. And a score greater than 6 is considered high risk. So as you can see, there's lots of there's a long list of things that are used to create this risk stratification profile. And I'll just highlight the more important ones on the next page. So the high risk factors, so obviously type 1 diabetes, which as we know is an autoimmune condition characterized by insulin deficiency. However, type 1 diabetes is only given 1 point. So it is obviously possible for people with type 1 diabetes to fast and fast safely as long as we equip them appropriately. A long duration of diabetes, so over 10 years, patients are more likely to have more brittle diabetes with more variability in their glycemic control. And obviously the big one is hypoglycemia. So we would be looking at their frequency of hypoglycemia, the severity, and most importantly, their awareness. So hypoglycemia unawareness is where a patient may have a low glucose level below 4 millimoles per liter and experience no symptoms. And this is a reflection of prolonged exposure to low glucose levels and likely frequent severe hypoglycemia. So if they do have unawareness, advice would be not to fast. So looking back at the 2001 EPDR survey, they did find an increased risk of hypoglycemia during Ramadan, with a almost 5-fold increase in people with type 1 diabetes and a 7.5-fold increase in those with type 2 diabetes. Keeping in mind, however, that this was a 2001 survey, and our diabetes pharmacotherapy has really come a long way since 2001. So back then, the cornerstones of diabetes treatment were metformin, the sulfonylureas, and insulin. And we know that insulin and sulfonylureas can increase the risk of hypoglycemia, whereas many of the agents that we are now using to treat diabetes, such as the DPP-4 inhibitors, the SGLT2 inhibitors, and the GLP-1 GIP analogs, do not carry an additional risk of hypoglycemia. So poor diabetes control, HbA1c greater than 9% is a high risk factor. Treatment, as we discussed, with insulin or a sulfonylurea. And recent acute complications such as diabetic ketoacidosis or hypoglycemic hyperosmolar state. So the diabetes complications to consider in this list, CKD, chronic kidney disease stage 4 and 5 are considered very high risk due to the risk of dehydration and worsening renal impairment, and immediately puts them in a high risk category. Obviously, patients on dialysis, renal transplant recipients, and those with unstable cardiovascular disease. If you have a suspicion or are aware that patients with these risk factors are still considering fasting, then it is really important that we help them at least do it as safely as possible. So the most important thing, I think, to advise patients is to reassure them that blood glucose monitoring does not break the fast. And the more information we have, the better control we can achieve. So the International Diabetes Federation guidelines recommend multiple points through the day at which to test the blood glucose level. So before suhoor, mid-morning, midday, mid-afternoon, before iftar, and then 2 hours after iftar, as well as any other time points during the day during which they feel unwell, have symptoms of hypoglycemia. However, this is really individualized, and some patients may not require such intensive glucose testing, but the more information we have, the better equipped we are to manage their diabetes. Continuous glucose monitoring is also a really good option, particularly in patients who are at risk of hypoglycemia. Now, this is available funded to people with type 1 diabetes, and many of our type 1 diabetes patients should be on continuous glucose monitoring. But devices such as the Freestyle Libre 2 are available even through pharmacies or online to people with type 2 diabetes. They cost about $110 to $150 per sensor. The sensor lasts 14 days, and it will give you a glucose level at any time point during the day. They just have to look at their phone. So this might be a good tool for those who are averse to checking their glucose levels so frequently during the day. So we have to tell people when it is advisable to break the fast and what are the risks of fasting for them. So low blood glucose or hypoglycemia, hyperglycemia, dehydration, and ketoacidosis. So what is a hypo? It is a glucose level below 3.9 millimoles per liter. A high level is a glucose above 16.6 millimoles per liter, or at any other time points during the day if they feel low or unwell. For people on insulin pumps, they have the option of suspending their insulin if their glucose level is dropping or below 5 millimoles per liter, or even higher than that, I would recommend. But they would also be advised to cease the fast if their glucose was below 3.9 millimoles per liter. So ketone monitoring. So all patients with type 1 diabetes should have a meter that can check ketones. So many, but not all glucometers have this capacity. So in type 1 diabetes, we always advise if they have a glucose level above 15 to check for ketones. There is the option of patients on SGLT2 inhibitors, if they are at high risk of ketosis, that they can also check their ketone levels if they are feeling unwell. And as we know, they are at risk of euglycemic ketoacidosis, so they may not necessarily be hyperglycemic, but still develop ketones due to the relative insulin deficiency. So educating these patients with regards to the symptoms of ketosis, so dyspnea, tachypnea, nausea, vomiting, and that, ketotic, sweet, fruity breath as well. Now, a bit more on type 1 diabetes. It is really an individualized assessment. There is very little data in this space. The studies are quite small. They're heterogeneous in their findings, with some studies showing no difference in glycemic variability and others showing an increased risk of hypoglycemia. As we discussed earlier, the APDR study was a retrospective survey with the largest cohort of type 1 diabetes patients, 1,070. And in this, they did find a higher risk of hypoglycemia during Ramadan than before or after. Having said that, technology has come a long way since this study, and we probably do manage type 1 diabetes differently since then. Then there are a couple of smaller prospective studies. And I thought it was interesting in the Darmina study, which comes from the Middle East and North Africa, as to how many people actually fasted. So in this study, it was small admittedly, but 77% fasted for at least one day, 72% for at least half of Ramadan, and almost 50% fasted the entire month. Which is contrary to the advice that we have been giving over the last few decades. And in this study, they didn't find an increased risk of hypoglycemia. But in the same year, another study from the Middle East was published, only 65 patients, but they did observe an increased risk of hypoglycemia and of breaking the fast. They also noted that there was less glucose monitoring than had been recommended by healthcare professionals. So what medication adjustments should we be making prior to Ramadan? Again, it's very individual. As a snapshot, metformin, usually no change. DPP-4 inhibitors, GLP-1, SGLT2 inhibitors, usually no change. But it is the sulfonylureas and insulin that will require some amendments potentially. So metformin, most patients we see are on once or twice daily dosing, and this can be taken as normal at suhoor and iftar, no risks. Patients on 3 times a day dosing can just distribute those doses across the two meals. Sulfonylureas, so these are medications like gliclazide, glibenclamide, glyburide. Thankfully, we mostly use gliclazide in Australia, which carries a much lower risk of hypoglycemia than the other sulfonylureas. However, the risk still does exist, and we may require a dose reduction. So if someone has tight glycemic control, so if their HbA1c is below 7%, we would consider reducing or ceasing the medication. But really, this needs to be guided by finger prick or continuous glucose monitoring. I've just been given the 1 minute warning, so I'll push on. SGLT2 inhibitors, we briefly discussed this last week, I know, during the cardiology talk. So the risk with SGLT2 inhibitors is volume depletion, genitourinary infections, and ketonemia. There have been a couple of studies which have not demonstrated an increased risk of ketosis or ketoacidosis during Ramadan, so the data has been quite reassuring, but we do need to consider special populations and their individual risk, like the elderly, those with renal impairment, those who are hypotensive or on diuretics. The recommendation is for the dose to be taken with the iftar meal, which might be different to when they had been taking it prior to Ramadan, as it's usually taken in the morning because of the urinary frequency that they might experience. Ensuring that they're adequately hydrated is really important. And again, if they are at risk of ketosis, then ensuring that they have a ketone monitor available. Now, these obviously are quite topical. So the GLP-1 receptor analogs, GIP receptor analogs. So these have been quite transformative agents in the diabetes space over the last couple of years. And we are talking, of course, about agents like semaglutide, which is Ozempic, and tirzepatide, which is Mounjaro. There are the older GLP-1 analogs like Saxenda, Victoza, liraglutide, and Trulicity. So the effects of GLP-1s are quite well recognized now. There are receptors in most organs, and so we know at the cerebral level they work to increase satiety. They increase insulin production in a glucose-dependent manner, so only after ingestion. Thereby, there is no risk of hypoglycemia as such. But there are also side effects. They're owing to the delayed gastric emptying. Many patients do experience nausea, and they can also experience constipation and altered bowel habits. So with regards to pure safety, we have limited data. Obviously, these are new agents, but there should be no risk in Ramadan with the use of these agents, and they should not require any dosing adjustments. But we need to consider the individual patient and whether they've been having side effects and how likely they are to experience these during the fasting hours. Often there will be a worsening of constipation in particular, so it is important that when they are eating, that they're eating well, having plenty of fiber and fluids. But other than that, we would continue as normal. Now, I'll just very briefly touch on insulin. So insulin is likely to require adjustment, and I encourage people to refer patients to their endocrinologist or GP to make adjustments prior to Ramadan. So these are, again, taken from the International Diabetes Federation guidelines. So patients on long-acting insulin or basal insulin, like Optisulin or Toujeo, it is recommended that the dose be reduced by 15 to 30%. Having said that, if patients have high glucose levels at baseline, we may not necessarily reduce that dose, so it does have to be an individual assessment. Patients on short-acting or rapid-acting insulin, which is generally taken with a meal, you would generally take the regular dose as you would with iftar because it is likely to be a high carbohydrate meal. Obviously at lunch it would be omitted because there is no meal, and at suhoor it is recommended that the dose be reduced by 25 to 50% to prevent postprandial hypoglycemia. Similarly, the pre-mixed insulins, Novamix 30, Ryzodeg, Humalog Mix, Mixtard, also do need to be adjusted, but this again will be guided by the individual patient's glycemic profile as to how to make those adjustments. In type 1 diabetes, again, in patients with good glycemic control, so HbA1c below 7.5%, it is advised to reduce the dose of basal insulin, but in those with higher HbA1cs, the dose could be kept the same. With prandial insulin, similar principle to that with type 2 diabetes with regards to adjustments. But again, with type 1 diabetes and type 2 diabetes patients on insulin, it is really all about the glucose monitoring, and the more they monitor, the more information we have about how to adjust their treatment. Just a quick note on exercise. Exercise will increase the risk of hypoglycemia and dehydration, especially for patients on insulin. So monitoring, and that will help us assess whether exercise is at all appropriate for people with diabetes. I'd had a quick question last week about hypothyroidism, so moving away from diabetes, and really the controversy here is the best time to take thyroxine, because we do recommend that this is taken on an empty stomach, usually 30 to 60 minutes prior to food intake. So when are we going to achieve that during Ramadan? Food, coffee, calcium supplements, iron supplements can all interfere with thyroxine absorption. So options include taking it 30 minutes prior to iftar or suhoor. Obviously, that will delay the time of your meal, or 3 hours afterwards, but there is probably no great time for it to be taken. But the take-home message here is really, it's better taken than not taken at all. So if there is no better time, just take it, whether or not your stomach is full. Some absorption is better than no absorption. So thank you, and I will end there.
Jazakumullah khairan, Dr. Nisa. Obviously, a very hot topic. We've got a few questions coming up on the chat box there. I might just quickly get two clarification from you because it's related. I think
Yes.
there was a question about that you mentioned the people with diabetes who would be at high risk. I think it was asking about what do you mean by unstable cardiovascular disease? If you could give a quick comment on that.
Look, I think we had a talk on this last week. So I don't think we have strong evidence to guide this space, but we're probably talking about people with unstable angina, symptomatic cardiovascular disease, or heart failure with reduced ejection fraction. But I leave it open to cardiologists to comment further if they wish as to when they would specifically disallow fasting.
Yeah, no problems. And then there was another question about, I feel like I should answer this question, but it was asking, do all GPs know about this risk stratification for diabetic patients and fasting?
I presume not. You really have to look for it. And it probably looks a lot more complicated than it is, but at the end of the day, there's a few standout risk factors, and really it's people on insulin and sulfonylureas who are at risk of hypoglycemia, people with poor glycemic control, so HbA1c above 9%, and with significant complications from diabetes like chronic kidney disease. But yeah, you're very welcome to look them up, and they're available. And there's a patient guide to fasting as well, which is a little bit less complex than the document that they have outlining how to do the risk stratification.
Yeah. So I can sort of just add on to that is, obviously the information is not widely known to all GPs, I'm presuming. And I think also as any medical problems, some GPs might not be well versed in fact, just specific management. Some GPs have an interest of diabetes management as well. So if you didn't get a right, I guess, if you didn't get a satisfying answer from your GP, you might have to just look for another one that might have interest in diabetes and obviously well versed in Ramadan fasting and things like that.
I think there's a lot of avoidance, both from patients, but potentially also from healthcare professionals, because there's not much known. And the easy answer is to say, don't fast. You have diabetes, you should not be fasting. But obviously, in a Western country, our experience of Ramadan and patients' perceptions is very different to what they would experience in a Muslim country. So we have to make it known. We have to disseminate the knowledge so that Muslim and non-Muslim healthcare professionals can manage these patients and their diabetes through Ramadan. However that might be. So it's I'm so glad we're having this talk now. I think there's some questions about Ozempic. Is that right?
Correct. So I just wanted to just take a general caveat. Obviously, we are unable to comment on individual medical issues. Our advice from today's talk will be general. So again, if you need medical advice for a specific question, you should obviously refer back to your medical professional. But I think, the last question was coming back to whether Ozempic is safe to use. And I think you can
I
add.
might comment just briefly on the use of these agents outside of diabetes, because I think that was brought up last week. And I think, as a population, we have to reframe how we consider people who carry extra weight. So we know, obviously, there are people who carry extra weight, with whatever class of obesity, who might be metabolically healthy and have no complications, metabolic complications. But we know from large scale, we have large body of data to show us that obesity is associated with poorer health outcomes. They are at higher risk of diabetes, vascular disease, metabolic liver disease, cancer, so on and so forth. So if we reframe how we think of weight and we think of it as a chronic health condition, much like hypertension or dyslipidemia, then I think that helps us answer that question, that if it is a chronic health condition, we should be treating it much like we treat hypertension or dyslipidemia. So yes, I think use of these agents is absolutely appropriate. It's just until the last few years, until recently, we had no effective agents to manage obesity. We have antihypertensives, we have statins, we have lipid-lowering agents, which have a very clear cause and effect. So yes, if we are managing metabolic health, then yes, Ozempic can be continued.
Yeah, no problems. And I think, yeah, the paramount message that I'm getting from you today is we need to, our bodies have a right on ourselves. We need to look after our body, and we need to be smart about our health. And as you said, we need to prepare well in advance, see your GP or see your medical health professionals months ahead to plan how your medication can be changed so that you can fast and things, so on and so forth. Inshallah. So without delaying much further, thank you very much, Dr. Nisa, for your brilliant presentation. We're going to move on to our next presenter is Dr. Omer Shareef. He's a neuropsychiatrist and a senior lecturer in JCU. He's also AIMA Vice President. He's going to be speaking to us about sleeping right in Ramadan, tips for recharging our body, inshallah.
Assalamualaikum, sister. Can you see?
Yes, we can see your screen.
Jazakallah khairan. Thank you very much. Thank you for the previous speakers as well. And thanks, Mr. moderating it. Fantastic. Thank you very much. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. So the topic is the Ramadan and how do we actually sleep right during Ramadan? Because sleep deprivation has significant impact both in our cognitive as well as in our physical performance, especially we being as healthcare professionals. It is paramount to make sure that we are performing at our optimal benefits. Although Ramadan itself has a lot of cognitive positive impact as well, but if we manage to sleep well as well, that can enhance the advantages which comes along with the fasting state as far as the brain health is concerned. So just on that, and my interest in sleep came from Quran. Quran talks about the variation which happens between day and night, the alternations, and at least in 37 places in the Quran, Allah talks about the alternation of the day and night, and there is a reason why He keeps reinforcing that, and that's why my interest in Quran, my interest in sleep came about, because sleep itself is a reasonably latest for branch of medicine. And so it's evolving in a fast pace as we speak. It has a lot of important revelation which came up only in the last decade as well. So in Surah Al-Isra, in particularly where Allah Subhanahu wa Ta'ala talks about وَجَعَلْنَا اللَّيْلَ وَالنَّهَارَ آيَاتٍ. So He talks about the night and the day are the two signs, and He raised the sign of the night and made the sign of the day illuminated, visible, that you may seek bounty from your Lord, and you know the number of years and count, and everything we have set out in detail. And Allah talks about this day and night variation, and we know that human beings are diurnal, hence we have sleep-wake cycle. And these are one of the important things to make us to be in a good shape, especially during outside. So deep sleep deprivation during Ramadan effects of Ramadan on sleep. Fasting alters sleep patterns. So when we are in the fasting, it alters sleep patterns. It results in shorter and fragmented sleep. And many people wake up for suhoor because everyone wakes up for suhoor and may stay up for tarawih as well. So these, because it reduces the duration of the sleep and to a degree its quality as well. We'll talk about it as well. And it also, since this, it also has an impact on the circadian rhythm, which is the sleep-wake cycle. Sleep deprivation during Ramadan can disrupt the body's circadian, leading to tiredness and reduced alertness as well. And we know from a couple of studies, again, with Ramadan and sleep, we have very low quality studies, and most of the studies, as our previous speakers mentioned, it's all done in Muslim countries as well. So replicating in the Western world may not be the right thing to do. But we have certain studies came out with, in general, in terms of sleep deprivation and how it can impact on our performance. So those kind of studies we have put down here. So the sleep of sufficient duration, continuity, intensity without circadian disruption is necessary. So this is what is necessary. The duration, and it has to be continued without fragmentation, and it has to be deep, slow as well. The intensity, the depth of it. It's necessary to provide high levels of attention and cognitive performance during the wake period. So for us to have this significant higher optimal cognitive functioning, we need to have a good quality duration and restorative sleep. Without that, it started to impact us almost within a day, and within 2-3 nights, it's going to impact significantly. Because sleep, we know sleep helps with the brain processing, different emotions, and it also processes the data which is got in, which consolidates as memory consolidation. It leads to novel solution to complex problems. It also enhances our creativity as well. So any sleep deprivation, which we often call as SD, sleep deprivation, has significant impact on the psyche, the mental concentration, memory, cognition, mood, and in general, the quality of life. And if we don't sleep very well, and this is often we see, especially in the month of Ramadan, we don't want this. If we can manage and sleep well, we could sleep like a baby. And that's what my talk is intent. And this is just about a general guide to how to sleep during the month of Ramadan. It doesn't address any specific. If you have any sleep disorders, of course, this doesn't actually be more relevant, and you should speak to your GPs and sleep specialists around that. This is generally as healthcare professionals, and if you're doing a high functioning jobs, even if you're not healthcare professionals. So having a sleep routine around Ramadan might have a significant advantage. So what happens? So let's look at what is sleep. What's the sleep? I'm just going to brush it off very quickly. Stages of sleep. What happens every time we get a bit of a eye shut? So what happens? What happens is we get into the sleep cycle. And the sleep cycle, the whole sleep cycle is around 90 minutes, around 1.5 hours. So we usually sleep around 4 to 5. Ideally, we should sleep 5 to 6 cycles per night, which is what is recommended. Sleep cycle is divided into 2 categories, and we all know this. This is non-REM and REM. REM is rapid eye movements, and non-REM is non-rapid eye movements. And non-REM is further divided into 4 stages. Which is very important to the restoration of our physiological health. Whereas in REM, it's more to do with our brain health. Although there is a lot of overlay between the both, but in general, this is how it's been looked into. Sleep cycles, so we're going into the non-REM. So we talked about REM and non-REM. Non-REM has 4 stages. Stage 1 is light sleep, so is stage 2. So people may experience a sleep movement or hallucination. You see a lot when you're about to go to sleep, you would see it. You have a jerky movement, it's like a myoclonus, and that's okay. And sometimes we feel like somebody's talking to us or calling our name from distance, and that's called as hypnagogic hallucinations. Don't worry, these are normal form of hallucinations. You're not getting psychotic or anything like that. But that these are some of the experience where before going to sleep, your physiologically, your systems are starting to slow down in preparation for you to put to sleep. If a person wakes up at this stage, it's like he or she may not have slept at all. We have gone through this many times in lecture halls, in particular when we are in students, even now perhaps. This stage lasts up to 5 to 10 minutes. And so that's also considered by the sleep scientists as a sleep warm-up of stage 1, to a degree stage 2 as well. So stage 2, again, it is light sleep. So that's conscious awareness of the external environment will be starting to disappear. A person can be awakened by a call. The body, the hormone is starting to reduce a little bit as well. And it also takes 5 to 15 minutes. So in a nutshell, the stage 1 and stage 2 takes up to 20, 25 minutes. That's the whole cycle. And it is still light sleep. And when you wake up, the person is still aware of the external, and they come back as if they haven't slept. So that's the stage 1 and stage 2 of non-REM sleep. Now we are going to the stage 3 and stage 4 of non-REM, which is actually deep phase of sleep, which is the deep, and that's what we call this deep, slow wave sleep. More effort should be made to awaken the individual. At this stage, the blood pressures, heart rates are at their lowest levels. If we have to awaken during deep sleep, which is stage 3 and stage 4, we often see we'll be groggy, disoriented. It takes some time for us to come back and starting to understand what's happening around us. Some children experience bedwetting, night terrors, or sleepwalking during this stage as well. So that's one of the 4 stages of non-REM. And now after non-REM finishes, the body gets into the stage of a REM sleep stage. And so the REM is basically a period usually starts around 70 minutes or 75 minutes. After we fall asleep, we have around close to 3 to 5 REM episodes at night. And we are not, although we are not conscious, the brain is very active. There are some certain stages of the brain during the REM phase is more active than our alert levels. So that is a lot of work that brain does during the REM phase of sleep. This is the period where most dreams occur. And usually when we get closer to the daytime, when we sleep during the night, when we get closer to the daytime, the REM starts to widen up as well. There will be more and more REM. It's in a way, it's Allah subhanahu wa ta'ala has designed our network so that it's preparing us to wake up for the morning. So that's how it is. And most of the time we also experience no dreams during the early part of or late part of the night or early part of the day. So rapid eye movements, because there's a darting of the eyes, so that's why it's called as rapid eye movements. The one important thing around it is all voluntary muscles are paralyzed, or skeletal muscles are paralyzed because of the spinal axis are being disjointed. And that's so that we don't enact what we dream. And that's a mercy of Allah subhanahu wa ta'ala that He managed to do that. So when we dream, we don't start to enact. And people who have problems with this disconnection of the spinal axis, that's where they have sleepwalkings and parasomnias and things like that, sleep disorders. After REM sleep, the whole cycle begins again, which means it goes back to the non-REM stage 1, night sleep, then stage 2, light again, then stage 3, stage 4, then REM again. And that's how it starts. So it goes through the whole 19-minute cycle. So again, we are doing this so that we don't want to go through this period during Ramadan. And it is often we think Ramadan, we are not having adequate nutrition or dehydration. Yeah, that could be part of it. But I believe it's more to do with the not managing our sleep very well. There is sleep deprivation slowly accumulating, which often makes us to become very tired during Ramadan. If we can manage that, we can enhance the experience of our Ramadan in much far better way. So this is one of the study which I found it very interesting. This is a sleep deprived human brain. So what they looked at is this is all about talking about people who haven't slept for only 2-3 nights, not somebody who is chronically sleep deprived. And if you see this side where it talks about the brain where the amygdala is they're looking at the amygdala reactivity during your sleep rested and sleep deprived. And is there any changes in its connectivity? So amygdala is one which often brings it is the emotional hub. It is where the fear centers and all sorts of emotions are activated. So when amygdalas, they actually find out any threat, the connection, it has a connection to the medial prefrontal cortex. But people with sleep loss, they have a reduced connectivity. So there is a threat which is being activated in our emotional hub, but it is not being able to resend to the medial prefrontal cortex, where it gives us reasoning, rationalization, or it also gives us problem solving, what to do next. So this connectivity is reduced. So it can put us in danger, because the one part of the brain identifies a significant threat, perceived threat, or real. But then our thinking brain is unable to process it and to help us to how to work it out. So which can be a little bit of hassle in our work life as well. So if it is the amygdala reactivity, if it is sleep deprived, there is significant increase in the connections, and there is a delay in the way things are processed to the thinking part of the brain. So if you look at the number B, it talks about the salience detection network activity, because again, the amygdala, and in this case, it has to talk to the anterior cingulate cortex and the anterior insula, and they have the salience network going. And with sleep rested, they have a high discrimination accuracy. What that means is basically, if you look at the number C, where the sleep rested mimica, there is a demonstration. When there's a demonstrator, there is demonstration, and the person should mimic what the demonstrator does. And when the person who is sleep rested, she almost able to mimic it as it is shown in the demonstrator. But whereas the sleep deprived, you can see that there is a significant missing out the accuracy of what the demonstration is. So the sleep deprived person is unable to fully visualize and understand the real facial expression. So there is a discrimination accuracy which is very low. So this is where the problem comes with sleep deprived, and inaccurate emotional face mimicry happens when with the sleep. So with the happy face, there's a sleep rested happy face thing, but sleep deprived, they miss out the happy face. But whereas with the sad face, with the threatened face, the people with sleep rested able to mimic it, but the people with sleep deprived is unable to accurately describe or mimic it, which is really serious stuff, because we see patients in clinics. If you're a surgeon, you will see in the surgery. And it is important how we work in teams with multidisciplinary as well. So how do we actually able to understand the nonverbal nonverbal communications, and how do you respond? So it can have a significant impact on a day-to-day life. So this is something I thought very serious if we are unable to regulate our sleep. So these are part of the cognitive functions. These are the higher cortical functions where we are able to understand people with nonverbal communication and manage to guesstimate the emotions which falls through. So it has significant impact. Reduced sleep can impair attention. Significant attention issues can happen. Focus and working memory, decision-making ability, problem solving can become slower or can be less accurate in some cases. It depends on the accumulative sleep deprivation. It's just not talking about one night. We are talking about if it happens for nights together, weeks. Prolonged sleep deprivation affects the brain's ability to consolidate memory and process information. Studies have shown that cognitive performance decreases as sleep duration reduces. For example, alertness and concentration can decline even after 24 hours of sleep deprivation. And we know that we all been junior doctors and when we are on call, and the next day would be, I don't have to say that, you know, how tiring, how difficult. Even when I hit my 30s, when I used to do night on calls, I stopped doing any financial transactions, any important financial transaction the next day, because I started to look at seeing that I'm not making a very wise decision. So that's how impactful it was. So then this is something which was done with the athletes. So we talked about the cognitive impact. Now do Ramadan fasting observance with associated. We are not talking about Ramadan on its own. We're talking about associated sleep deprivation with decreased sleep duration. Does that have an impact on the daytime sleepiness and among the student athletes? So the data is very clear in this. So it did have. So there was a decrease in the energy levels and lack of sleep impairs muscle recovery after physical exertion, potentially leading to fatigue and reduced physical performance. So the hydration helps to mitigate some of the things, but sleep deprivation on its own is a big detriment here. Studies showed a decrease in physical performance in athletes who were sleep deprived during Ramadan fasting. These are some things we know, but we don't actually take into consideration. We think it is Ramadan, I have to exert myself. Yes, we have to exert ourselves, there's no question about it, but we need to prepare for it. We should have done that exertion in the month of Sha'ban. So then by Ramadan, when it kicks in, then we are in a position to get into the act straight away. But when we put so much of pressure upon us and we're still working, it puts in a significant level of stress. And thereby there is a risk associated with it. So this is another study which they did with this large group of people, 24,500. They looked at it, examination of sleep in relation to dietary and lifestyle behavior. This is something our speakers have already touched earlier today and last week as well. But I thought of just reminding myself of this, so how important there is significant linkage between what we eat and how we sleep. So cross-section, this was a cross-section study. It was done in 27 Muslim countries. The questionnaire assessed were dietary and lifestyle factors. They were independent variables, and they took some sleep parameters as dependent variables. So out of this, they found that the 7 hours was significantly associated with sufficient physical activity and consuming plant-based protein. The people who are actually slept well up to an optimal level of 7 hours are people who consume most of plant-based protein and fruits and vegetables and dates. They had a better sleep quality. That says a lot. And then the smoking was significantly associated with greater sleep disturbance and poor sleep quality as well. If anybody we are in the habit of smoking, Ramadan is the best time to quit it. And we have to quit it because it does a lot of damage to our health and to the environment we live in. And Ramadan is a great opportunity for that. And one more thing is it affects our quality of sleep as well. Infrequent consumption of delivered food like takeaways and junk foods and frequent screen times. So if you reduce screen times, if you reduce junky foods, it improves our sleep quality. And that comes from some multinational study as well, 27 countries. So data is quite good. Now we talked about the studies. Now we put into practice. So at the moment, for this year, in Australian major cities, most of them are in Melbourne, Sydney, largely based on these two areas. So we are looking at a mean of around 15 hours and 13 minutes of fasting, and Hobart being the Tasmania being the longest. So we are talking about 14 hours of 13 minutes of fasting in 24 hours. That leaves us non-fasting or eating window period of 8 hours, 30 minutes. So eating window period is of 8 hours, 30 minutes. That includes our sleep time as well. So now we have to work around how do we actually better manage our sleep within that. So that's what the next few slides are going to talk about. So just be with me. so that you will understand what is this about. So we are looking at some kind of approximation in terms of Ramadan sleep schedule. I've taken the Victoria and New South Wales because that's where the large group of Muslims live. That's not to say Queensland and Adelaide and that are not this, but I thought just for giving a scenario, I tried to quickly, maybe it's a selection bias as well. I put on some kind of times which can vary. It varies according to the location, but I've given an approximate time. So I'm going to put a sleep schedule. It's not going to start from Fajr. If you're looking at it starts from Fajr, no, it's going to start from Isha. Why I did that? Because we start the Ramadan from the Ramadan night. So I post Maghrib, so it starts with Isha. So that's how I'm going to follow the cycle. Because post Shaban, Ramadan comes, we don't hit the day, we hit the night. So it starts with Maghrib's, post Maghrib, Isha, then Tarawih. So that's the algorithm I followed in this schedule. So Isha Jama, roughly around 9 p.m. It can vary according to your locality, but and Tarawih can be around 90 minutes. So the Tarawih finishes around 11 o'clock. And then we have to wake up for Tahajjud at around 4 a.m. And then we have the Suhoor around 4:30. So the time we have left with 11:30. So by the time we come home, we get into our bed and try to be comfortable so that the sleep latency comes in and we fall asleep. Maybe another 30 minutes, maybe 45 minutes, but for the sake of this, I've taken 11:30 and we are sleeping around 4 hours. So that's 4 hours, 30 minutes. We are sleeping. So that's 4 hours, 30 minutes. Definitely that's not enough because we need at least 7 hours of sleep. So then the Suhoor starts at 4:30 a.m., then the Fajr Jama at 5 a.m. Then we come back from Fajr. Then we usually go to work around 8 o'clock, but we need to get ready around 7 o'clock. Again, these are all approximation. So we have around maybe 1.5 hours between Fajr and going to work. So how do we actually utilize it? We can do a nap time, which is around, what is power nap? Power naps are around 20 minutes. So when we sleep for 20 minutes, that's called as power naps. We can actually have an alarm set for 20 minutes and then another alarm for 20 minutes. So we have 2 power naps. Why do I say that? If you would have followed the stage 1 and stage 2, stage 1 and stage 2 are light phase of sleep. So when we get out of that sleep, our brain is recharged, but we are not coming out groggy or disoriented because we haven't entered into deep slow wave sleep. But if you sleep on a stretch to 40 minutes, you are at risk or endangering to get into the stage 3 of non-REM sleep, which is deep slow wave sleep. To come out of that, you will find it very hard. It may take a couple of minutes, sometimes even a few hours. So that's why it is important that we break it into 20 minutes, maximum 30 minutes. After 30 minutes, we are at risk of getting into the stage 3 of non-REM sleep phase. So it's better that we sleep for 20 minutes, having an alarm, then snooze it, take another and make it 2 alarms. And then you have another 20 minutes power nap and then wake up. And that's going to recharge yourself very well. If you can't do that, then you have solid 1.5 hours, then go for 1 sleep cycle, just 1 sleep cycle. So the alarm should be at 1.5 hours. So if you go with sleep in Ramadan, it's better you orientate yourselves to sleep cycles of 90 minutes rather than the time you have. For example, if you use the same example to 11 hours, 30 minutes to 4 a.m., we have 4 hours and 30 minutes, which is roughly, you can do 3 sleep cycles in that minute, in that time a lot available. So it's 3 sleep cycles and then 2 power naps. That's almost the night and the initial part of the day. And then you're off to work. Then you're back again. Asr Jama at 4:30. You post Asr, I'm supposed to be back at home at 5. If you're in a place where there's a lot of traffic, it might take longer. But just for the sake of this, I put as 5. Then you come back, then you still have some time to do some power naps for 40 minutes. And then 2 power naps and then Maghrib. So you're basically having 4 power naps and 3 sleep cycles. So that's basically takes us our sleep cycle to close to 7 hours. So we have to break it up this way and to work around it when during the post-Fajr time and post-Asr to Maghrib time. That's the best way to work it out to make it as best as possible. So 3 cycles and 3 to 4 power naps as well. That will all work out together as 7 cycles, 7 hours in a day. But daytime sleeping is far, far inferior than nighttime sleeping, unless you do power naps, which has the recharging, which recharges and make our brain to work more efficiently than going to the full sleep cycle. I think my time is up, so I'm just going to finish it here. So what is sleep hygiene in Ramadan? And so 3 to 4 sleep cycles of 90 minutes. Sleep and caffeine. If you wanted to take caffeine, caffeine has an half-life of 12 hours, quarter life of 8 hours. And if you come after the Tarawih and have a caffeine, you're not going to sleep well. There's no deep, slow wave sleep. You might feel you're sleeping, but your brain is not sleeping. You might have more REM phase of sleep rather than non-REM phase of sleep, and you might wake up very tired. Same goes with nicotine. They both are psychostimulants, caffeine and nicotine, and they're going to keep your brain awake and alert. So it's not going to make your brain to go to stage 3 and stage 4 of deep, slow wave sleep. And master power nap. If you can actually try the next 5 days before the Ramadan comes in, try to do this. Put a routine into place. Only you can't wait until the first day or the first night of Ramadan. Then you'll be really tired the next morning. But if you can put something into place before Ramadan kicks in, this will have a huge impact. Sleep's our routine. Put a routine as well. Get smarter with your smartphone. Don't make your smartphone to be smarter than you. So find your way to relax. The sunnah is the better. There's more slide, but I'm going to stop here. Jazakumullahu khairan.
Jazakallah khair, Dr. Omer. MashaAllah, a very a good, deep reflection on sleeping. Now, you're not going to get away because you're the only thorn among the flowers in terms of presenters today. So I just wanted to let you know that the amygdala theory, I think a lot of Muslim female sisters who are mothers in here would agree with me that we have overpowered our amygdala connection with the sleep deprivation. And alhamdulillah, I think our mimicry is still working really well, Dr. Umar. I think maybe you should do a study on Muslim female mothers, inshallah, to highlight the theory. But alhamdulillah, we've been practicing. So for the mothers out there, they know what sleep deprivation means. So we've been practicing before Ramadan. Inshallah, in Ramadan, we can fly faster than the male counterparts.
I agree. Definitely, there is a lot of advantages. Mother is an amazing being, is a blessing. But there is a inert attention given to our own children, and we know their facial features more than we would know from a stranger or from somebody else. So obviously, mothers would be in a better position to identify the emotions of their children, even though they haven't slept for a few nights, better than the strangers or people they meet.
Alhamdulillah, alhamdulillah. Now, that was really intriguing, but I'm so sorry that I had to give you a little bit of a warning with the time. Being mindful, we have, mashallah, we had more than 50 participants, and people are still actively asking questions. Maybe just quickly, there's a question about how about caffeine after suhoor?
Yeah. What happened to the rest of the speakers? They have to go?
No, they're still here.
They're brilliant.
Yeah, they're
Okay.
still here.
Brilliant.
But they have to be here for the question and answer.
Yeah. No, I understood that I'm the only one caught it. That's fine.
No.
But that's fine. So I misunderstood that. So it's just with caffeine after suhoor is the best way to do, unless you don't want to do a power nap. But then there is another theory as well, which is called as caffeine power nap. So when you take a caffeine after suhoor, you definitely know you would come up more energetic in 20 minutes because of the caffeine, which is going to replace the adenosine, which is accumulating in the body to put us to sleep. But the only risk with that is that when the adenosine when the caffeine is eventually displaced, probably midday, then adenosine comes back with a vengeance and sits back into the same receptors. Then you might find a significant caffeine drop. So you might find it that you are more tired by midday. So that's the little bit of a risk involved. But if you have slept 6 to 7 hours and you are somebody who's early riser and you've done that always, and you wake up around 5 a.m., 4:30 a.m., and that's your normal routine, and that's fine. So you'd have your suhoor, have your caffeine, and your day starts, your activity starts. So that's fine. Otherwise, if you plan for a power nap after Fajr, that may not be the best way.
Okay, no problems. Jazakumullah khair. Now, before everybody leave, just be mindful that we do have the QR that we're going to share at the end about you recording this activity as your own sort of self-directed learning. And you will get a certificate of attendance if you follow the link from the QR. And when you fill in that form and get the certificate of attendance, you can actually submit it to the college and receive your CPD hours as appropriate. Now, just before I go to question and answer, I would like to share very, very quickly. Just going to share my screen if everybody can see it. So we all may have heard, but there is the AIMA National Conference in Melbourne on the 19th to 20th of April. I attended the AIMA National Conference in 2023 as a medical professional. It was life-changing, mind-blowing. It was really empowering to see speakers speaking about the deen and medical profession come together in one setting. And this year we've got extremely renowned speakers internationally and locally. And one of them is Ambassador Ibrahim Rasool, that's coming all the way from South Africa. We've got Dr. Gabo Mate joining us via Zoom. Most of us would know him. We've got Dr. Musa Nordin from Malaysia and multiple others international speakers that are very well known. And not to forget our local speakers. If I can say anything, this is probably one of the best investment for any professional development that you're going to spend for this year. So please, inshallah, if you can make it, the tickets are being sold right now as we speak. So just follow you can follow the link through the QR there. All right, so without further ado, we're going to go straight into our question and answer. So what I'm going to do is I'm actually going to allow everybody to ask the questions. So I'm going to allow you to ask the question. If you put up your hand and then if I pick your name and then that way we can have some sort of making sure everybody's not speaking over each other. Give me 1 second. All right, so if anyone has a question, and I see Sister Maureen. Go ahead, Sister Maureen.
Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khair for such an amazing webinar. Please correct me if I misunderstood the last session. I wanted to clarify if there's a way to get around optimizing sleep pattern while maintaining the sunnah of staying awake after Fajr. Is there a way to get around that? And I don't have much knowledge around that. So I also wanted to clarify around the time between Asr and Maghrib. If someone wants to optimize that time and maximize ibadah during Ramadan and not sleep, how do we get about that? Is there a way? Jazakallah khair.
Jazakallah khair, sister, for your question. Ideally, that's what the Ramadan is for. Ramadan is the time for, it's an examination. Ramadan, Allah subhanahu wa ta'ala has made it that way. The Satan's are being changed, so we are less tempted, less influenced. And so we are able to do things much which pleases Allah subhanahu wa ta'ala. So we can easily indulge in the state of ibadah. So that's given. But the question is this, if we have a sleep deprivation for 1 night, 2 nights, we can cope with it. But if it continues to be the case for the couple of nights and day for a week, then we tend to become very tired. And we sometimes invariably, this is exposed from us to the team we work with. So that puts us, as well as the deen, the religion we follow in a certain way. So, and we also understand from the sleep researchers going across the sleep labs, the impact, the cumulative effect of sleep deprivation on the cognition, especially at the attention levels and how it can impact our performance levels, both with and personal. So this is where I'm trying to say. I'm saying if you manage to do it, then there are people who can only need 3 hours, 4 hours. There are people like Zakir Naik and some few people, they openly say they sleep less than 3 hours, 4 hours. But those people are very few and far. They're not the average people like you and me. If I sleep only 4 hours per night, for 3, 4 nights, I'm really tired. I can't actually be myself, and I'm not being able to do it. So the question of it is, if you leave the work out, but if you leave the work issues out, and if you look at the ibadah alone, so the impact of our attention, the impact on our concentration, the impact on how we actually do our ibadah can be compromised as well. Because in Ramadan, we have to give the best of our ibadah. Because we haven't slept well, and the fatigue goes in, and the brain connectivities are not working, there is almost like a mini neural shutdown happens because you're not sleeping well. The sleep is the only time the brain is getting locked in. That is how household chores happens when we sleep in the deep slow wave sleep. There are glial cells which is activated, and it's called as lymphatic clearance. It's almost like a mopping of the brain. If the brain is not mopped very well for subsequent nights, then you actually see a lot of clutters in the brain, and that's not allowing us to be in the right frame of mind. We are not able to optimize our brain function at the way it needs to be. So it will have an impact at work, at personal level, as well as the ability to do our ibadah at a quality. So I'm not saying you need to sleep, but I'm saying there is no time, especially when we are having fasting for 15 hours, working almost 9 hours in that 15 hours, then we have very less time to work around it. We can't compromise the obligatory prayers, the Tarawih, the Camel Lane, which happens in the last 10 nights. But wherever we get some chance, we need to sweep in some power sleep, which is 20 minutes al. I'm just trying to sell this concept. How you're going to pack that power nap during the day, that's up to you. But I'm just giving a sleep schedule. And it's not bad to say that's the best way.
Jazakumullah khair. I don't see any other hand, but I've just got some question from the chat box, probably for Dr. Nisa. 2 questions, but you could probably briefly answer both of them. What is your advice on patients with type 2 diabetes breaking their fast with dates or honey? Also eating them in general, even if they're not fasting, in terms of the effect they have on people with type 2 diabetes?
Yep, thank you. Common question. We get a lot of questions about dates and diet. So it's really individual, and I don't know what the effect dates is going to have on your blood glucose level. So someone with, relatively good insulin sensitivity will tolerate eating dates. Their glucose will not go high. It'll be within the healthy range. It'll be perfectly fine. But everything is individual. So it might be that one date for you will shoot your sugar up to 12. I don't know. I can't answer that until you've tested your glucose levels. So my suggestion would be, speak to your GP or endocrinologist or whoever's in your healthcare team. If you have a glucometer, use it and test it. So have your dates, have one date, try with one date, see what happens to your glucose level an hour after that date, 2 hours after that date, have 2 dates and give it a trial it, see what happens. Usually it is the amount of carbohydrate that you have in a short time frame that will send that glucose high, that will elevate the level. So absolutely, if you're having a couple of dates, having a break for Maghrib and then coming back for your meal, it's unlikely to have a huge impact. But if you're having that date combined with 3 samosas and spring rolls and whatever else, then it probably will shoot the sugar up. So yeah, I hope that answers the question.
No problems. And just you mentioned this on your slide, but briefly, there was another question about someone if they're taking metformin 500 milligram BD, should their dose be reduced after suhoor? Again, it's not an individual advice, but just in general regarding metformin and fasting.
Yeah, so metformin does not cause hypoglycemia, as long as you're not also taking, something like gliclazide or insulin. So no changes are required. You can have your metformin as usual across the 2 meals. There's no risk with that.
Jazakumullah khair. And there is another question. It's obviously we try not to touch on the fiqh aspect, as there may be differences of opinion. So there was a question about getting IV vitamin infusions during fasting, including vitamin D or vitamin C. Would that invalidate fast? Again, not an individual advice, but I guess the vitamin D perhaps is your forte, Doctor.
Look, vitamin D is not typically administered as an infusion, so typically it's taken as a tablet or a high dose tablet, or occasionally in people who are very vitamin D deficient and not responding to oral supplementation, then we give them an IM injection. That can absolutely be done outside of Ramadan, and a vitamin D tablet can be taken outside of fasting hours. So I don't know what the necessity for an infusion is, particularly during that month. I would presume that if you are having non-life-saving fluids, then it's probably not advisable during fasting hours. If you want to do it, you could do it outside of fasting hours. If you are so unwell that you require an intravenous infusion of something during Ramadan, then you probably shouldn't be fasting if you are that unwell. But if you're talking about those sort of those wellness infusions and whatnot, my assumption would be that you would just do them outside of Ramadan.
Sure. Just
Yes.
if anyone has a question, feel free to raise your hands and then unmute yourself if you would like to ask anything. So Dr. Marrwah is also still with us. Yeah.
So can I just add, we have the fiqh issues. We have a template which was published by the AIMA and the Muslim Council of Britain, and that's in our website in AIMA. And it is part of the, if they go to the Ramadan Initiative webpage, we have attached that details there. So what is allowed, what's not allowed, and that's based on the Mufti as well, who is a doctor himself, and he works very closely with NHS in the UK.
No problems. Jazakallah khair, Doctor. There's another question about type 2 diabetes. With the dietary indulgence in Ramadan after iftar, is there any long-term complications of the elevated sugar levels within the hours of iftar to suhoor and then fasting during the day? I think
So we don't have good data with regards to this. So if your glucose level becomes elevated and remains elevated, then you are at risk of acute short-term complications of hyperglycemia. It really but no, if you're saying intermittent hyperglycemia over a 1-month period, we don't have good data to support that is associated with any long-term complications. But it's individual basically. We don't know what your level of glycemic control is inside and outside of Ramadan, but you would want that glucose level to be coming down. The risk of the acute complications is if it stays elevated and is not coming down afterwards.
no problem. Thank you, Doctor. So perhaps I just have one last question to Dr. Marrwah. It's not really a black and white question, but you probably, from your experience, if a pregnant woman or a breastfeeding mother asks you advice about fasting, and they're concerned about the risk of things that might happen to them. For example, if they say, I'm worried about getting a kidney stone because I have a history of it so if I breastfeed and I get dehydrated and I'm fasting, and they're just worried about those risks. How do you maneuver these conversations with the patients, Dr. Marrwah? Perhaps just share your experience if you don't mind.
Yeah, of course, Dr. Anna. So I think, as you said, it's not a black and white thing. There is a lot of nuance, and a lot of the counseling that we give is individualized. So something like kidney stones, we know that a significant risk just from
So sorry,
Ramadan
Dr. Marrwah,
fasting.
could you just repeat that last part again?
Did you lose my voice a little bit?
We did, yes.
Sorry. I don't know what's wrong. It can be dropping it. But I was just saying that in general, people who have, for example, renal calculi in the past outside of Ramadan are at increased risk. And so, and as part of the guidelines that Dr. Shareef shared, one of the, I think one of the criterion is experience from previous years of fasting. So if someone's had a previous adverse experience, and would recommend that they alter their fasting habits on that basis. And if they've had a negative experience outside of Ramadan and they're worried about that, it really depends on what it is. But some things there may be expert opinion or evidence. If there isn't, you often could say, depending on what the problem is, trial fasting outside of Ramadan or during Ramadan, and if it's causing any problem, to take a break for a day or two before trying again.
Jazakumullah khairan. Thank you. And I think if there is no other questions, let me just have a look if there's any other hands up at the end.
I think someone's written a question in the chat. I just saw.
There you go.
Is there any information about Ramadan fasting circulated to our non-Muslim colleagues who take care of Muslim patients, for example, through RACGP? So I don't know about the College of GPs, but I know that it's not necessarily circulated amongst the medical colleges, but there is, I think, a lot of increased awareness now amongst healthcare professionals that there are consensus statements or information available, particularly through the hard work of the British Islamic Medical Association. So I do tend to refer to them. I also know that, as Dr. Shareef alluded, there is the IDF data as well. So there is information out there. And I think that patients who have an interest in or care for Muslim patients will seek that information. And it is widely and easily available and circulated on the college sites, to my knowledge, unless someone's had a different experience.
Yep, you're right, Dr. Mara, and yes, someone's shared one. And yes, I've shared earlier the AIMA Ramadan website, in which the link to the other resources from BIMA and so on and so forth is available as well, inshallah. All right, so I think if there are no more questions, I've got the screen up here with the QR code for you to get your certificate of attendance. So feel free to do that. So without keeping you all here any longer, I would like to say a big Jazakumullah khairan to all the speakers. MashaAllah, may Allah reward you for the knowledge you've shared, for taking time to prepare and empower us all that attended today with the knowledge that we really need before the beginning of Ramadan. And the best thanks that we can give to you is the dua so that Allah subhanahu wa ta'ala rewards you with the highest of reward, inshallah. So we'll just end today with a small dua, inshallah, and may everyone have a beautiful Ramadan and blessed Ramadan with their family. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين اللهم بلغنا رمضان اللهم بلغنا رمضان اللهم بلغنا رمضان سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone, and have a beautiful evening, inshallah.
So, thank you, Sister, for moderating. So I appreciate it. Thank you. Mr. Nisa, Sister Marrwah, thank you, Jazakumullah khairan for your time. It was very beneficial. We learned a lot. And that's good to talk. We appreciate it.
Jazakallah khair. Dr. Shareef, your talk as always was very informative and educational.
Oh, thank you. No, I enjoyed well, both of yours actually. I'm just hoping I can find that much time in my day to sneak in some naps.
That's a $1 million question.
I don't know where. Inshallah. Inshallah.
Inshallah.
Yeah.
Yeah.
Thank you for all of you. Thank you. Jazakumullah khair. Yeah, it is correct. The Ramadan sleeping pattern is very, very bad sometimes. I wish if we can regulate our sleep and circadian and we can follow your advice, Dr. Shareef. Thank you. Thanks. Yeah.
Jazakallah.
Alaikum. Alaikum.
Alaikum salam.